Thank you. So traumatic glaucoma, I have no financial interest in this presentation. It has a very wide spectrum. But first, before we go into the details of traumatic glaucoma, let's understand why do we get glaucoma in case of injury. The moment we have an injury, the first part of the eye to take the burnt is a cornea, and we get some sort of indentation. Sometimes there may be a tear. In case it skips a tear, the maximum force is passed on through the angles, and this is the area which bears maximum burnt of trauma. Also, iris, there can be changes in the iris, and zonules can be affected. Sometimes lens displacement, dislocation, or breach in the capsule of the lens can take place. So all these structures like cornea, angle, iris, zonules, lens, these are the main structures which bear the brunt of trauma. Sometimes there may be vitreous hemorrhage or involvement of retina, but in those cases, the prognosis is really very bad. So once we are looking at a case of traumatic glaucoma, we need to look for changes in the conjunctiva, like any signs of conjunctival tear or any changes in the underlying sclera, changes in the cornea. If it is possible, if it's a closed glove injury, we can go and check the intraocular pressure. Our main focus should be to look at the iris changes and angle changes if the situation permits. If we are able to do gonio, we can go ahead and do. Otherwise, it would be ideal to wait for some time. And we should look for hyphema if it is present. The presence of hyphema indicates that definitely the trauma is of some significance. We need to look for lens displacement, if any. And in case the visibility is poor, we need to do a B-scan ultrasound to get an idea of what exactly is happening inside the eye. Now, I would like to go for a case-based discussion based on what regular cases we see in our OPD. Coming to the first spectrum of cases, like these are simple cases, like say this 14-year-old boy who was injured with a cricket ball with minimal contusion injury. And this kind of injuries we usually treat with antibiotics, steroids, and if required, the pressures are on a higher side or say borderline, we add one anti-glaucoma medication, say a beta blocker or so. And I usually defer the gonio examination for 1 week if the patient is not cooperative on day of examination. In this case, with one anti-glaucoma medication, the pressure was almost borderline to normal range. And these cases usually do not require surgical intervention. I follow these patients at 4-monthly interval for 1 year and thereafter on yearly basis. Now, in a more difficult situation like a major trauma, a 16-year-old male was hit with a cricket ball. His pressures at presentation were very high, 34 millimeters of mercury. Initially, we started treating him medically with antibiotics, steroids, AGM, and this particular injury was repaired. In follow-up, we saw that even with like maximum possible medication, his pressures were on the higher side. And we could do gonio after 1 week, which showed no obvious angle recession. Even he had a severe injury, but somehow the angle structures were spared. Ultimately, for high IOP, he required TRAB, and the pressures were controlled after 2 months. We waited for some time. We continued the medications, hoping that the pressures will come down. Once it didn't come down, we went ahead with TRAB. Now, this is a common scenario that we have. Another 21-year-old male who was hit with a stick, and what we saw was anterior segment was largely okay, except for the hyphema which was present in the anterior chamber. So we treated him medically with tapering dose of steroid, antibiotic, and with cycloplegic agents. Over a week's time, hyphema resolved, and his pressure was almost in the acceptable range. And since there was no angle recession, we kept him on observation 4-monthly for 1 year. Hyphema can have a spectrum of presentation. It can be very less minimal hyphema, which we can absorb. Sometimes it is say up to 50% of the anterior chamber, wherein we can consider drainage. In other situations, it can be almost full chamber hyphema, also called 9-ball hyphema. In these cases, they could be associated bleeding in the vitreous cavity also. And the pressures will definitely be high in these kind of cases. So anything above 50% of total hyphema, we have to consider that pressure will be high and glaucoma procedures, some sort of intervention, glaucomentation will be required. And in 30% cases, there can be a rebleed. If we see this picture, we can understand that he had at least 3 episodes of bleeding in the anterior chamber. And if there's a full chamber hyphema, if the hyphema is not resolving in 1 week's time, there might be chances of corneal staining. So this we should keep in mind. So whenever we have a situation like this, within 1 week, we should consider going for an AC wash, and especially if the pressures are above 25 millimeter of mercury, there's no point in waiting for even a week. We can go for early intervention also. If ultrasound shows vitreous hemorrhage, then possibly we have two options. If we can take help of our retina consultants and plan for a combined vitrectomy also, if it is a persistent high IOP with thick blood in the vitreous chamber, or if you think that the vitreous hemorrhage is not much, then we can go ahead with the anterior chamber wash with trabeculectomy. Again, trabeculectomy is a bit controversial, but if there is a severe damage, then it is better to go ahead and do trabeculectomy if the pressures are in very high range. Now coming to another case of trauma, like this 34-year-old male had a road traffic accident. If we see carefully, you'll see that there is iridodialysis in this part, and he had hyphema, irregular pupils. There was iridodialysis at 9 o'clock position, and angle recession from almost 10 o'clock to 4 o'clock. Almost 12 hours of angle recession was noted. What happens in these cases is blood, plasma, and other debris, they tend to clog the trabecular meshwork. Also, there is injury directly to the meshwork, also causing inflammation. And this injury can, in a later stage, cause a scarring. So overall, initially, the IOP is high because of inflammation and debris. And in the later stage, the trabecular meshwork doesn't function that well, leading to high IOP. Now, this patient, we started on anti-glaucoma medications, his pressures were controlled with 4 medications initially. And when we have angle closure, once the inflammation is well controlled, when there is less of reaction, then we can consider starting prostaglandin analogs also, because this medicine increases uvascular outflow. So normally the use of prostaglandin analogs is controversial in the initial phase, but once the inflammation is less, we may consider this because it is effective in IOP control. There are 2 IOP spikes in case of injury. Initially, for first 1 year, there can be episodes of ups and downs. And later, when the patient completely forgets about the episode of trauma, there can be another spike, say around 10 years later. So for these patients, a close follow-up or yearly follow-up for a lifetime is advisable. I would just like to explain what exactly happens in case of angle recession. Here, if you see this patient, the iris is attached to the ciliary body exactly at this point. But from here, we see angle recession. If you see carefully, it's like a split of the ciliary body muscles. So at one part, we can see one group of muscle. On the scleral side also, there is a muscle fibers which are attached on the scleral side also. It's something like a split with muscles on both sides, and we see that the angle is deep. Now, coming to a case of cyclodialysis, this is a 34-year-old male who was a football player who had injury on field. He presented with high IOP and pain. His AC was quite deep at presentation also. When we could do examination of gonio, we saw that if you see here, like you will see that there's a whitish area here, which represents earlier attachment of ciliary body here. So the entire ciliary body has receded back because of the impact of the injury, and AC is quite deep, and this is called cyclone dialysis. So he had both in the temporal side, he had angle recession, and on the nasal side, there was cyclodialysis. Now, these two factors have opposing effects. Angle recession leads to high IOP because trabecular meshwork is not functioning well. Cyclodialysis sometimes can lead to low IOP because the aqueous gets a channel to pass through the uvascular channel. See, if you see here, this would be the normal angle here because of recession, and here you see increased passage or almost a tunnel kind of a structure because of cyclodialysis. So because of these opposing factors playing a role in the same eye, the patient was stabilized just on one anti-glaucoma medication. Now, another spectrum of case, the patient had an injury with a hammer, and when he presented, the lens was at the pupillary border. We didn't realize that the lens had totally got dislocated. His IOP was high, and for evaluation, we dilated him. The moment we dilated, the whole lens was in the anterior chamber. So this was a case of traumatic lens, initially subluxation, but in clinic, it became dislocated. So in these kind of cases, the only option is to go ahead and remove the lens. The patient was ultimately stabilized on 2 anti-glaucoma medication, and later we did SFIOL with TRAB for him. Now, initially, in some cases, there might be AC shallowing following trauma, and we can try. If the lens is clear and reasonably well supported, the PI may help and the glaucoma may be under control. But if there is a significant cataract, as in this case, the only problem that this patient had was intumescent lens, in these cases, we have to go ahead and operate and remove the lens. In lens-related glaucoma, sometimes there can be blockage of the trabecular meshwork because of lens particle release. It is best to avoid anterior chamber lens or iris fixated lens in these cases, and it's better to prefer either a capsule or bag IOL implantation or to go ahead with scleral fixated IOL based on the situation on table. Now, last few slides only. So this case was an open globe injury. The patient hit with stick. There was a corneal tear. In fact, I would say corneal tear only. If it is not involving sclera, is a good case. There are chances that if it is well repaired, the glaucoma chances would be less. These cases may escape secondary glaucoma. Now, in these cases where we have iris prolapse, it's damage to the sclera also or the limbus, there are high chances that secondary glaucoma will happen because of mechanical damage to the meshwork initially, and the inflammation may cause scarring of the trabecular meshwork later in life. The method of following these cases would be initially watertight closure and foreign body removal to prevent fibrous ingrowth and epithelial ingrowth. Here, if you see, there is the ingrowth of endothelial tissue, of epithelial tissue, which is very difficult. Secondary glaucoma caused by these cases are very difficult to treat. So in these cases, if required, we can go ahead with trabeculectomy augmented with mitomycin or Ahmed glaucoma valve. But many of these cases do proceed to the stage wherein cyclodestructive procedure is the only option. But it would be ideal, or it would be very important to remove the foreign body if any is suspected. The last category of cases in my presentation is chemical injury. If the patient presents with chemical injury, initial management is just to treat the high IOP spike, but sometimes the IOP can be low also because of ciliary shock. But in later stage, definitely the IOP will go up. And we have to remember that there would be a good amount of conjunctival scarring, and these cases trap may not work. So for these situations, it would be ideal to go for a tube surgery or to prepare the patient for cyclodestructive procedure. So in conclusion, I would like to say, initially, we should try to control the patient's symptoms and attempt medical control. We should buy time, delay the surgical procedures as much as possible. But still, in any case of trauma, we should be ready for surprise. On table, there can be sudden dislocation of lens, AC shallowing, rebleed, and we should inform the patient regarding these management concerns beforehand only. And the patient should be informed that he will require lifetime follow-up, as there is a bimodal presentation, many cases present years later. Thank you very much.